I'm Mandy Benning. I'm a cerebrovascular, open and endovascular neurosurgeon. My fellowship is in cerebrovascular neurosurgery, so that means that my expertise is in the treatment of vascular disease of the brain. So that includes strokes, aneurysms, carotid disease, arteriovenous malformations, really anything that has to do with blood vessels of the brain or spine. There's two different types of stroke. There's ischemic stroke and hemorrhagic stroke. And ischemic stroke is the most common. That's when a blood vessel is blocked and then that portion of the brain doesn't get oxygen. Then there's a hemorrhagic stroke, and that's when something bursts, like an aneurysm or arterial malformation, or maybe a small vessel burst from high blood pressure. But essentially, whether it's ischemic or hemorrhagic, a stroke will cause a sudden onset of neurological symptoms, whether it's headache, numbness, tingling, weakness, speech disturbance, visual changes. I always say it's called a stroke because it's like lightning came out of nowhere and struck you, and so it usually comes without a warning. Stroke is diagnosed, first of all, by the symptoms. There are strokes that can be silent, and we see these from time to time where a patient will have an MRI or CAT scan and we'll say, "Did you know you had a stroke?" and they won't know. But for the most part, strokes have symptoms such as numbness, tingling, weakness, speech disturbance, visual changes. So if those symptoms happen to you, you need to immediately seek medical attention, call 911. And then we can confirm whether or not it truly is a stroke with imaging such as CAT scan or MRI of the brain. The other thing that's important to understand is that stroke is a very time-sensitive disease. I think that everybody is very aware of signs and symptoms of heart attack, and so if you get chest pain, you call 911 or get to the ER, but you'd be surprised how many patients will have stroke symptoms like weakness of an arm or something, and then go sleep it off, hoping that when they wake up, everything has resolved. And that's really the opposite of what you want to do, because most of our treatments are time sensitive. If you get to the ER too late, it'll be too late to offer those treatments. So one of the most common treatments is something called clot buster medication. And really that's, for the most part, offered within 4.5 hours of the onset of symptoms. We do have some protocols at GNI where we can actually extend that window up to 9 hours, but it's a very small subset of patients who can fit in that 9-hour window. So the earlier you get to medical attention, the better. Then if you do have a blockage of a large artery in the brain to where the blood flow is not getting to the brain, we can diagnose that with CAT scan as well. And then in certain cases, we can actually do a catheter angiogram and retrieve that clot out of the vessel and restore blood flow to the brain. Again, that's time sensitive. Every second that your brain is starved of oxygen, you're losing brain cells. So the sooner you can get to medical attention, the better. The people most likely to have a stroke could be anyone, actually. You always think of stroke being in older patients, maybe those with more risk factors, advanced age, but truthfully, we see strokes in all age groups and all demographics. Typical risk factor for stroke are diabetes, high blood pressure, high cholesterol, smoking, genetics. If you had mother and father who had strokes, then you might have a higher chance of having a stroke. But we also see strokes in younger and younger patients, and a lot of that has to do with the fact that we're seeing adult diseases in children and adolescents now, a lot of times from obesity. You can also have strokes even from trauma or injury to a blood vessel. Sometimes you can have what's called a dissection, which is an injury to a blood vessel that tends to cause strokes in younger patients. Whenever I see patients with a sudden onset of neurological symptoms, I think stroke, and I don't try to fit anyone into a box of, oh, you're too young to have a stroke, or not in the right group to have a stroke. It can happen to anyone. In order to prevent stroke, we tend to say that 80% of strokes can be prevented by managing risk factors. And so that should really start early in life, and that includes healthy diet, exercise, not smoking. If you know that you have a family history of high cholesterol, stroke, heart disease, you want to get these things tested early so that you can make sure you're either on a right diet or the right medications to prevent high cholesterol or diabetes. And the earlier you manage these risk factors, the less likely you are to have a stroke. I always say that if everyone managed their risk factors from an early age, stroke would be a much less prevalent disease in the US and the world. Having had one stroke does put you at higher risk for having a second stroke. And whenever somebody comes in with a stroke or a TIA, which is otherwise known as a mini stroke, we always want to figure out why did that happen. And so, some patients will have abnormal heart rhythm, something called AFib. We want to make sure those patients seek consultation with a cardiologist and that they're on the right medication. If it's a matter of poor diet or diabetes, high blood pressure, we always want to manage those risk factors by changing the diet, getting the patients on the right medication. And then it's not just a one-time thing. It's not like you're in the hospital, we change your medicine, and then you don't need to worry about it again. This is constant maintenance. So really we want to make sure that patients have routine follow-up with their primary care physicians, cardiologists, neurologists, to make sure that we're monitoring these risk factors to help prevent a second stroke. So in terms of stroke research, there is a lot of attention in stroke treatment. We've done a good job of educating the public what stroke is and stroke symptoms. But even though it's gone from like the third to the fifth leading cause of death in the US, it's still the most common cause of disability in the US. All of our research is really focused on decreasing the disability caused by stroke. So number one is prevent the stroke if you can, but if you do have a stroke, what can we do about it? So we're always looking to extend the window of treatment. The clot-busting medication, we can extend that window to 9 hours in some cases. For retrieving a clot out of the brain, we can extend that window in some cases to 24, maybe even more than 24 hours. And then we're also looking at, what happens to those brain cells that have been starved of oxygen for a certain period of time. Is there something that we can do to aid in their recovery, such as neuroprotective medications? So we're actually in a trial where after we get the vessel open, we bathe the brain cells with a medication that's known as a neuroprotectant agent. And so we're really always looking at how can we help those cells recover and how can we limit the disability caused by stroke.